Our speaker today is Kimberly Meyer. Ms. Meyer began her career as a staff nurse in the trauma ICU over 20 years ago. Since that time, she earned a master's in nursing and now serves as a neurosurgery nurse practitioner at a busy Level 1 trauma center. She has authored numerous articles and book chapters related to neurotrauma. She is currently a PhD student at the University of Louisville, pursuing research interests in traumatic brain injury and paroxysmal sympathetic hyperactivity.
Thank you. So today I'd like to discuss paroxysmal sympathetic hyperactivity following traumatic brain injury. If you've been working in a neuro or trauma ICU for any length of time, you may have actually heard this by other names, and we'll talk about each one of those. Before we begin, just like to go over the course objectives. By the time you finish this, it would be really beneficial if you could identify the symptom clusters associated with sympathetic storming or that paroxysmal sympathetic hyperactivity, or PSH. Recognize that there may be triggers that commonly occur that initiate these storming episodes. And then finally, discuss recommended treatment modalities for the symptom clusters that occur with sympathetic storming. I have no financial disclosures, but do feel obligated to tell you that I am on the CDC concussion definition work group, as well as the Neurocritical Care Society CBT guideline committee, specifically looking at anticoagulation in neurotrauma patients, and then also serve as a subject matter expert for the surgical neurology journal, the Nursing Quarterly, that's now being published. Society of Trauma Nurses is an accredited provider of continuing nursing education through the American Nurses Credentialing Center. This event has been awarded 1 contact hour for full completion, and the materials will be available on demand, will expire on January 31st of next year. To successfully complete this and earn CEUs, you must attend the entire course, and you must verify by signing in and complete the evaluation form. So now that we've covered all the housekeeping, let's go on and talk about sympathetic hyperactivity, paroxysmal sympathetic hyperactivity after traumatic brain injury. I'd like to first start with a case study, and this is a little more challenging via webinar, but I'd like to share with you a gentleman named Marshall, who's a 20-year-old young man who was involved in a car accident. And you can see this is an MRI taken from partway through his hospital course. And you can see here, if the arrow shows up, yes, you can see that he has some hemorrhages here within his corpus callosum, kind of tagging onto the end of his basal ganglia here. Some in the splenium of the corpus callosum. More concerning, you see on the other image, this black dot here in his brainstem. These are all signs of diffuse axonal injury following his high impact injury. You can also see that he's had a right-sided craniectomy for subdural. And if you get your microscope out, you can look at these vital signs. These are taken about a screenshot of his record taken about 10 days into his hospital course. And if you look at the vital signs, you can see that his heart rate has been variable throughout the course of the day, ranging as low as in the 60s and as high as in the 130s. For a 20-year-old, you can see, who's already on a little bit of sedation, you can see that he remains fairly hypertensive off and on throughout the day. And so forth. So as an ICU nurse or even a floor nurse taking care of someone who you know has traumatic brain injury with diffuse axonal injury, these should all trigger in your mind that something is going on with this patient. And to the less experienced, you might consider that he's having some kind of cardiac event because it's his heart rate and his blood pressure that are the predominant problems. Perhaps part of the reason his respiratory rate has been less affected is he still is being sedated and is on the ventilator, although that is not very well reflected in this flow sheet. So what is paroxysmal sympathetic hyperactivity? Well, we believe that it's an exaggerated stress response that can be seen after traumatic brain injury. It's also been documented in the literature to be noted after certain brainstem gliomas, particularly in children. You can see it sometimes after subarachnoid hemorrhage and other cases where there's injury deep inside the brain itself, closely related to the brainstem and the deep structures of the brain. The incidence following trauma has been reported anywhere from 15 to 30% of patients in a coma following traumatic brain injury. And it's thought that this is a fairly, in most patients, a fairly short occurring event that lasts during the first maybe 4 to 6 weeks after their injury, but it can persist into the post-acute care setting and has been reported at up to 10% in the rehab setting. It can be seen as early as 24 hours following an injury, although I would argue that if you're seeing that in someone with a severe traumatic brain injury, they're probably undersedated for the level of their injury. Most commonly, it occurs days to weeks later, and often presents when you begin to wean off the medications that have been treating normal ICU care and ICP care. So when the fentanyl drips come off, the propofol drips come off, the midazolam, that's when you start really seeing some of this hemodynamic instability that is often associated with paroxysmal sympathetic hyperactivity. We know that when you start having these episodes of storming, as I'll call them for short, that it can increase the overall morbidity, and it does that because it can cause prolonged periods of hyperthermia, so their temperature goes up, sometimes in relation to infection, but other times it can spike throughout the day without any other obvious cause. It can cause excessive catabolism due to some of the excess movement that can be seen. And it results in high catecholamine levels. So if in these patients during these episodes, if you were to send some of their urine to the lab and measure it for epinephrine and norepinephrine levels, you would see really high levels, and that creates a chronic stress response that can cause adverse effects to the body. And then finally, one of the other symptoms is spontaneous posturing, or what they consider to be some dystonia-type movements. And if those aren't treated urgently, the patient can go on to develop contractures and have chronic problems with chronic immobility. Paroxysmal sympathetic hyperactivity has been called many other names. Most recently, it's been called sympathetic storming or autonomic dysfunction. Back in the 1920s, it was called diencephalic seizures by Dr. Penfield. It's also likened to things that we see more frequently in spinal cord injury, like autonomic dysreflexia or autonomic hyperreflexia. However, over the last year and a half, there's been a group of rehab and neurologic specialists that have convened. And because these episodes tend to occur spontaneously at different cycles throughout the day, they thought that the term paroxysmal sympathetic hyperactivity would be a more fitting and more encompassing name. And so that is what you are starting to see become more prevalent in the literature. There's several different theories about how these symptom complexes occur. As I mentioned earlier, they were originally thought to be seizures coming from the diencephalon. Further development of electroencephalography has shown that that is not the case. There's no seizure activity evident on electrical imaging. There's also some discussion that these may be caused by some disconnection within the brainstem to the higher level cortical areas, so that you lose part of the negative feedback that comes from the hypothalamus. But the most widely accepted is actually the excitatory-inhibitory ratio model, where you have all this afferent stimulus that gets processed, and it doesn't, and it totally lacks the inhibition as it goes back to the brain. And so you have all of this hyperdynamic state and due to excessive catecholamine release. So this is just a picture to show you where we think the pathology is arising. Down here around the tectum, the tegmentum, and then this whole area is the diencephalon in close proximity to the pons, or the upper part of the brainstem. And this schematic just shows how normal transmission usually gives feedback from the cortical surface of the brain, and it goes down and is relayed through the brainstem, the pons, into the spinal cord, and then comes back up. And with the sympathetic hyperactivity, you lose these interruptions and the different inhibitory neurotransmitters that normally slow things back down. When we consider the pathophysiology, we know that there's an initial insult that causes the disruption in brain function. In our case today, we're going to be talking about brain injury, but recognize that it could also be the subarachnoid hemorrhage, the brain tumor. But it causes a mechanical or structural disruption within the brain. And it may also be associated with some rapid rises in intracranial pressure. We often don't see this because by the time it becomes evident, the ICP monitors have come out, and so we're just assuming that that's part of the pathophysiology. As I said, it results in a disassociation between the sympathetic and then the parasympathetic system, so you have no negative feedback to slow things down, and it results in an uncontrolled state of stress. This causes a hyperadrenergic outflow. As I mentioned, there's increasing levels of circulating catecholamines, in particular epinephrine and norepinephrine, and these over time will result in the dysfunction of various organ systems. So what we predominantly see as primary symptoms usually come from the cardiovascular system. We see increased cardiac heart rate, we see increased cardiac output, and if you watch the patient, you can actually even see how fast and hard their heart is beating. I always liken it to people who are actually having the catecholamine dump that is associated with brain death. If you've ever apnea tested someone, take them off the ventilator, you can see how hard their heart is pounding. Sometimes you will get that same appearance in someone who's suffering from these paroxysmal sympathetic hyperactivity episodes. When you look at the pulmonary system, if you were to bronch the patient, you would, I'm sorry, these keep popping up, you would see bronchial dilation, but clinically what we tend to see is tachypnea, so it can be a challenge to get these people off the ventilator because you're afraid that they're breathing so fast they're going to tire out, so the trend is to just sedate them more and try to let them rest more, but you have to recognize that this is going to be an ongoing problem, and sedation is not going to be the appropriate long-term solution. When you look in their eyes, their pupils may be dilated. You may see, remember with the fight or flight response, which is basically what this is in an ongoing mechanism, that your gut tends to shut down. So if they're having a lot of these hyperactivity episodes, you may see decreased GI motility. And if you think about that as a nurse, you see that as them not tolerating their tube feeds, they have higher residuals, they may have some emesis that is associated with it. And then finally, when we look down to the musculoskeletal system, they can develop contractions, muscle wasting, and then the adrenal glands obviously are responsible for the release of the epinephrine and the norepinephrine. We can never just assume in a critically ill neuro patient that we know the diagnosis right off the bat. We have to consider a differential diagnosis, and high on the top of our list is a neuroworsening. So often it requires imaging to ensure that there isn't a new lesion, development of hydrocephalus, or some other pathology that could be causing these symptoms. As well, we mentioned hyperthermia or fever is associated with this, so we always have to be diligent in ruling out infections. This patient population is at risk for developing seizures, so some of these conditions may require EEG monitoring 30 minutes or sometimes even prolonged monitoring to make sure that you're not having seizure activity before you settle on the diagnosis of PSH. Also need to consider things like thyroid storming, neuroleptic malignant syndrome, and then withdrawal from either opiates or benzodiazepines, although those are much less likely to occur. PSH tends to occur in stages. The first stage has been described as the asymptomatic phase, and we think that's because of all the sedation that's required for general ICU care of the acute traumatic brain injury patient. Stage 2 begins with the onset of symptoms, and this stage can last for several months, but there's been one study that shows that it may even go on for 5 years, up to 5 years. The end of phase 2 is characterized by the cessation of sweating that you will often see in these patients. And then finally, phase 3 is evident by a decline in the dystonia and posturing that sometimes occurs. To diagnose PSH in this population, first we have to have a documented severe traumatic brain injury. And then you will see a constellation of intermittent symptoms. And some authors propose that you have to have 5 of these symptoms in order to call it PSH. So 5 occurring roughly at the same time or in close proximity of each other. As I mentioned, tachycardia and hypertension tend to be the predominant symptoms, followed by tachypnea and then diaphoresis. This is not just a little sweat. These people just pour buckets of sweat. You can't keep their linens dry. You can't keep their gown dry, and they're at risk for dehydration because of so much insensible water loss. You can also see spontaneous posturing that's not related to a neurocheck or any other kind of stimulation. The patient just lays in there and tends to take an extensor tone that can be very difficult to break. As we mentioned, the higher temperatures, you can see the pupils dilate, and then the dystonia kind of goes with the posturing. It can be associated, these episodes can be associated with what we call triggers or events that precede the episode, and it's thought to occur with just regular nursing care, such as suctioning, repositioning. There's also some concern that even excessive sensory stimulation, so if you have your monitor alarm set too low or too high, and so there's always monitor alarm in your room, that may actually trigger enough noxious stimuli to trigger one of these events. May be brought on by early onset infections where you truly have an infectious fever that kind of sets this up. But many times we find that there's nothing that sets these episodes off, and so we really have to be diligent in monitoring. So as you're taking care of your comatose traumatic brain injury patients, there's a few signs that should make you go, and those would be those predominant symptoms, that tachycardia, hypertension, tachypnea, and diaphoresis. If you're seeing those occur in combination in cycles throughout the day, so you have periods where they're normal and then periods of just what appear to you to be unprovoked tachycardia, tachypnea, hypertension, diaphoresis, that should always put up your little antenna to wonder if your patient has PSH. And then the other signs of the abnormal motor response, the pupillary dilation, and then increased tube feeding residuals would also strengthen that concern. It's associated with diffuse axonal injury, so almost all of the patients who develop PSH have some form of diffuse axonal injury, and those injury patterns are associated with injury to the corpus callosum and the brainstem. So I showed you Marshall's picture with the brainstem injury. Here's a little bit of a flare signal in this patient. This is a different patient, but a little bit of flare signal in the brainstem, and here's some gradient echo sequence up here in the corpus callosum again, and a little bit more in the back. Occasionally, you have to undertake other diagnostic tests. EEGs, if they're done, most often show delta and theta waves, but no specific epileptiform discharges, therefore ruling out any seizure as the cause of these events. Catecholamine levels are not routinely done. They tend to be very expensive, and really they don't alter your treatment plan at all. As opposed to an EEG, if you did see seizure activity, you would make sure to continue their anti-epileptic drug. If they have high levels of catecholamine, there really is no treatment for that other than getting their heart rate and their blood pressure down, which you're already doing. So then you have to move on and consider the treatment. And so some of the hallmarks of treatment for PSH, your overall goal is to mitigate the signs and symptoms to reduce the potential adverse events. So if you have these cardiac symptoms that go untreated, over time the patient can develop cardiac hypertrophy and even myocardial infarction, subendocardial damage. They can also become very dehydrated, and you'll see that manifest as a high serum sodium or increasing BUN. And it's just related to the free water deficit secondary to the profuse sweating. Muscle wasting, because they have this spontaneous posturing throughout the day, they use more calories than your normal comatose brain injury patient. So it's suggested that you work in close concert with your dietitian to make sure that the patient is getting enough protein-related calories to prevent muscle wasting. Working with the therapist to make sure that they have functional splinting to prevent contractures, because once the patient develops contractures, it's very difficult to undo those. And we feel like if you can get a good handle on these patients with storming early, control their symptoms, then they still can be rehab candidates. Whereas if you let them go untreated, then they're more likely to be diverted to, after acute care to a subacute or even a skilled nursing facility, where their likelihood of getting brain injury rehabilitation is very low. And finally, working to prevent what I call delayed recovery throughput. And what I mean by that is the patients with storming tend to have longer lengths of stay in the ICU. They tend to have longer hospital stays. They're more likely to go to a subacute or skilled nursing location than an acute brain injury. And so you want to really try to prevent all these or minimize all these signs and symptoms so that you can optimize their recovery potential. How do we treat PSH? I wish I could tell you that there's a certain cocktail that you use on every single patient. It works every time, but unfortunately that is not the case. There's been case studies of several different drug classes, and each show different kinds of benefits in different patients. But what you'll see are the most commonly used drugs are opiate receptor agonists, so standard fentanyl, morphine, roxicodone, those kind of things. Other drugs like dopamine agonists are also very beneficial. And then non-selective beta blockers. It's our tendency in today's ICU world to use metoprolol to fix every kind of heart rate problem there is. However, we have to recognize that actually this hypertension and tachycardia are coming from a central process, not the heart itself. And so metoprolol is not actually helpful at all in these cases. You have to go old school and break out the non-selective propranolol so that you get the CNS effects of it to help gain control of those symptoms. As well, alpha blockers have been used, GABA agonists, but most often what is necessary is a combination therapy, and not every patient needs the same drugs. But some that I have found particularly useful over the last year or so have been a little combination of scheduled opiate, gabapentin, and bromocriptine, or perhaps an opiate, propranolol, and some baclofen if they're having more of the motor issues associated with storming. So let's go through each of those classes individually. So opiate receptor antagonists, your typical opiate drugs fall into this category, and they seem to work by modifying the autonomic nervous system changes and to help decrease that hyperdynamic cardiac function and decrease the posturing episodes. It tends to be dose dependent, and so putting people on low doses does not seem to be very effective. You have to have higher doses. And so often what we'll do to try to gain control is to start them at 10 milligrams of roxicodone scheduled every 6 hours or so. And then as you gain control, you can taper them back down to a more standard dose. GABA antagonists are drugs like baclofen and gabapentin. Baclofen works by, they think it works by acting on the inhibitory interneurons in the spinal cord. And as you know, baclofen tends to be very sedating, so it's not an optimal drug when you're trying to have your patient wake up from a coma. Studies have shown that if it's given intrathecally, either through a lumbar puncture or even through a ventricular catheter at microdoses, it has a significant impact on symptoms without having all the lethargy and drowsiness that's associated with the higher doses of oral or enteral baclofen. Gabapentin is thought to act on the alpha-2 delta subunits in the dorsal horn of the spinal cord, and so help to mediate that neuropathic transmission of what would presumably be a noxious stimuli to these patients. And it has been shown to reduce the severity of the episodes, and it also reduced the requirements for concomitant medications so that you can use lower doses and even fewer numbers of medications if you have a little bit of gabapentin on board. When we talk about the dopamine agonists, the drugs that we classically use are bromocriptine and amantadine, although some authors advocate the use of levodopa. These agents have shown variable results in reducing the storming episodes. But one particular study, it was a case series, showed that bromocriptine did tend to, in particular, decrease the episodes of temperature and sweating that were associated with storming. As I mentioned, beta blockers, they help reduce the severity of episodes and decrease the circulating catecholamines, thereby reducing the cardiac workload, placing less stress on it, and reducing the catabolic drive. Always remember, and you have to do a lot of education with your physicians, that cardiac selective drugs are not effective. Propranolol is the most effective because it crosses the blood-brain barrier and blocks the serotonin receptors and helps slow all of that catecholamine release down. The main alpha agonist that's been used has been clonidine. They think it works by acting centrally as well as peripherally by blocking the adrenergic influences to the brainstem. It also has been shown to reduce the circulating catecholamines without really affecting cerebral blood flow. So you know that when you give clonidine, it can lower your blood pressure, and in this patient population, your concern is that you lower their cerebral perfusion pressure and their cerebral blood flow. But this does not appear to be the case. It did help control the blood pressure, but it really didn't have effect on the temperature or the frequency of episodes in at least one study. So that is paroxysmal sympathetic hyperactivity in a nutshell. I'd like to show you a case study now, which is actually a very atypical case. This is so PSH tends to be seen in patients who have lower Glasgow Coma scores, more significant diffuse axonal injury. But I illustrated this case because you could see the difference the medications made on a very quick basis. So this is the 22-year-old right-handed gentleman who was admitted in February after falling 2 stories off a balcony. He was unresponsive at the scene. His Glasgow Coma score on admission, he had no eye opening. He was intubated for airway control, and he was localizing weakly. His pupils were 2 millimeters and brisk bilaterally. When he arrived to us, he got a CT scan of his head, which demonstrated a left cerebellar contusion. And as you'll recall from your clinical experience, posterior fossa trauma is really fairly infrequent. So you know that this affected, if it affected his cerebellum, there was likely some impact to the brainstem as well. He had a left basilar skull fracture with temporal bone fractures, some traumatic subarachnoid hemorrhage, as well as some parietal and temporal contusions on the right. So really he had a global diffuse type of injury. So here's his CAT scan. He has the cerebellar contusion right here. He's got this scattered out traumatic subarachnoid hemorrhage, maybe a little bit of blood layered out in the tentorium. You can see that he probably has a little bit of edema. You would like to see his basilar cisterns here a little bit more open. Although him being 20, you would recognize that he probably doesn't normally have a whole lot of CSF in his head. And then here you can just see some of his basilar skull fractures going through here. I'm sorry, the box is over top of it, so I can't see all of them. So his hospital course for the first week was fairly routine. He was sedated on the ventilator, not having too much trouble. His ICPs normalized fairly quickly. He didn't need any aggressive therapy for his intracranial hypertension. So by day 7, it was felt that he was ready to have fentanyl and midazolam drips weaned off. So at that time, he was noted to have a temperature of 100.5 degrees Fahrenheit. His heart rate was up into the 120s. His respiratory rate was in the 30s. And here you are with a 20-something-year-old with a blood pressure of 180/90. These were treated as individual symptoms with nicardipine, oxycodone, and by then I had done enough education with some of the ICU staff that they did choose to use some propranolol, particularly for the heart rate. Day 8, he was noted, this was some very nice nursing notes, so the other reason I chose to include this. At 10:30 in the morning, he was noted to be shaking. He had a heart rate of 140. He was breathing fast. He was sweating. They gave him the propranolol as ordered. But at 11 o'clock, he was still kind of getting worse, so they turned his fentanyl and midazolam drips back on. So the thing you have to keep in mind that when you give enteral propranolol, it takes longer than 30 minutes to take effect. So it's not surprising that he continued to get a little bit worse for a little while. But by 11:30, even with the IV drips back on, he now had a heart rate that was greater than 170. So he was given some metoprolol and some midazolam boluses. And then if you kind of kept reading through the nurse's notes, he kind of settled down. And then, again, 8 o'clock, his pupils were reactive. He had some intermittent tachycardia and ICP spikes, but returned to normal without any intervention. The next day, the fentanyl and midazolam were still going. The nurse felt like he was storming because of his heart rate and his blood pressure. The next morning, still storming and restless. So he gets medicated by, I believe it was by the trauma team who put him on a bunch of atypical antipsychotics, the quetiapine and the risperidone. They held his propranolol actually due to some bradycardia. I believe his heart rate was in the 50s, but instead they gave him metoprolol and labetalol IV because they were shorter acting, and he was still having such issues that he required at least one vecuronium and a couple of midazolam boluses. So now you get into problems with polypharmacy. You start putting atypical antipsychotics on a patient who you're trying to wake up, and you're actually slowing their recovery down. I'm not going to be so worried about bradycardia in a patient who's 20 years old. He probably runs closer to bradycardia in the first place. And I'm giving drugs that I know aren't going to help, and then these just kind of are going to prolong his ICU stay and prolong his recovery. I think I was out of town during part of this. So I find him a little later in his hospital course. He's agitated, tachycardic, and hypertensive. And so they were describing this agitation that he was kicking his legs around, and so they would restrain him, and then they would give him some more quetiapine and so forth. But by this time, he had had significant neurologic recovery. He was now opening his eyes. He was still localizing. He was pretty purposeful. He was on the following medications. So once again, we have just an alphabet soup of medicines that may or may not be appropriate, starting with hydralazine, some intermittent propranolol, some oxycodone, some midazolam, some fentanyl. Some clonidine I saw was ordered, but it wasn't but it was never given because of I want to say blood pressure issues, but I'm not for sure about that. So I added in just a little gabapentin. And with that, he kind of settled down a little bit. We were able to get his ventriculostomy out. He started following commands, which was a good sign for us. And the nurses said that he was restless, but you'll note that pretty quickly after the initiation of the gabapentin, his vital signs were within normal limits. And that was on a much shorter medication list. Gabapentin, propranolol, the scheduled oxycodone, and the midazolam and fentanyl drips were coming off without any difficulty whatsoever. So this goes back to that study that shows that you need less medicine and fewer medicines with the little gabapentin added in. Moving along in his hospital course, he was still restless and agitated. His mom said that he was significantly worse at night because she was staying with him 24 hours a day. So a colleague and I decided that we were going to kind of go in and do a little more of an exam than we normally do in these kind of patients. So we sat him on the edge of the bed. And what we noted was some involuntary flexing of his left leg and hip. So it really wasn't that he was cognitively agitated, but he was having these dystonic movements of his leg that everyone was interpreting as agitation. So he continued with the gabapentin because it had worked so well. We were weaning his propranolol because now we had his heart rate controlled, and he even tended to be a little low. But we added some bromocriptine for these abnormal motor movements. And we didn't want to give him anything to worsen his neurologic function or slow down his recovery. So at night we added just a little bit of melatonin to see if it would help him sleep, since he tended to do so much worse at night. So by the time we got him to hospital discharge, he had spontaneous eye opening. He was following commands. He attempted to vocalize, told his mom that he loved her. He still had some dystonia, but it was better, and it wasn't interfering with his neurologic care. It wasn't interfering with his overall medical care. He was able to sit in a chair for an hour or two at a time with decreased psychomotor movements, for lack of a better term. His vital signs had been normal. He hadn't required any PRN medications for either his blood pressure or his heart rate or his respiratory rate. And so we were able to get him off to acute rehab on day 17, as opposed to, had he gone along his original trajectory, he would have probably still been in the hospital 30 days after injury with less neurologic recovery. So I want to really stress to you that this is a diagnosis that's very difficult for a provider to make just based on review of the ICU flow sheet. It's really critical that nursing has direct communication with the providers to tell them what is going on that's not always well reflected in the charting. So there's actually a thing called nursing surveillance recognized by the Nursing Intervention Classification System. And you can see here that it's the purposeful and ongoing acquisition, interpretation, and synthesis of patient data used for clinical decision making. And these are, pardon me, can be involving checklists, interdisciplinary rounds, different clinical information systems, but that you should have some mechanism for relaying information that you see in the clinical setting to appropriate people. So not only do you need to relay it to the provider who has the authority to order some medications, but a lot of times this spontaneous posturing and the dystonia can be alleviated with direct conversation with your physical therapist. If you, I know our physical therapist is very big on getting a lot of hip flexion going to break that extensor tone that can be associated with these storming episodes. So really want to impress upon you that you are the best person to identify which drugs help and which ones don't. It's kind of silly to keep giving medicines that don't seem to have any long-term effect on the symptom complexes that you're seeing. And so really work with the medical team to make sure that you are giving them information that can be used to alter the treatment plan accordingly. Here are some general recommendations for treating storming episodes based on the predominant symptoms. And so this is how you may have to tailor your cocktail to meet the patient's needs. If it's cardiac that predominates, then propranolol should always be a first choice, recognizing that the cardioselective drugs are not overly useful. If diaphoresis is a big problem, then gabapentin and fluid replacement, either extra water down their Dobhoff tube or their G-tube, or even some IV boluses may be necessary to prevent dehydration. If abnormal movements, posturing, extension, those kind of things are the problem, then perhaps they need a little bromocriptine or amantadine added in. If it's agitation or you're not sure what it is, but they just tend to be moving all over the bed all of the time, then those are good candidates for opiates. They're also good candidates for valproic acid, not for its anti-seizure effects, but because of its effect on regulating neurotransmission within the brain, and can really help with that agitation. And recognize, too, that this is a helpful drug not just in storming episodes, but if you have patients who are prone to post-traumatic agitation, a little combination of valproic acid and propranolol can really get them off the other sedating drugs and benzodiazepines fairly quickly. You always want to avoid haloperidol in a traumatic brain injury patient because there are studies that show that it impairs the dopamine transmission such that it delays their brain injury recovery by several weeks. Atypical antipsychotics, I'm not going to say never use them because I do prescribe them myself, but they should be more down your treatment algorithm and not the first thing that you go to. Clonidine can also be used, as I showed you, the studies show that it can be useful in some patients with storming, but once again, it should not be first line because it has such a negative effect on cognitive function. And then finally, if posturing and spasticity are your problems, then functional positioning and baclofen may be your best recourse. Baclofen, you can always start at low doses so that you don't have such effects on arousal. But if your posturing and spasticity are such that they're not responsive, you can always up that to a maximum of 20 milligrams 4 times daily. Cyclobenzaprine really doesn't have any effects on this kind of spasticity, so really should be avoided. Diazepam can be used in critical situations where positioning for medical care and nursing care is nearly impossible, but it should not be a first-line drug either, just because of its persistent effects on neurologic function. So you, as the nurse, can save the day by recognizing the signs and symptoms of sympathetic storming or paroxysmal sympathetic hyperactivity. You can also help to identify the triggers. So you, if you note that every time you go in to turn your patient that he has these episodes that last 30 minutes or so after you turn them, those will be the patients that you want to see if you can pre-medicate before you go in, just to do that very simple basic care. Or perhaps those patients, although we don't routinely do it, those patients may need some modified suctioning or any other trigger that may that you may notice. I do this, and this patient goes haywire. Then you need to see, number one, do I need to keep doing that procedure? And then number two, what can I do to pre-medicate to prevent this from happening? Always make suggestions for appropriate therapy, because you've been with the patient longest and you know what has worked and what hasn't worked. And then really need to focus on the family and educate them that this is very scary for them. They always worry, especially if they're having the posturing and movement problems, that it's a seizure. So educate them once it's confirmed that this is not a seizure, that this is something that we're going to try to control the symptoms, and that over time these symptoms will decrease and eventually they'll go away. But we don't know how long. It's very individual how long the symptom complexes last in every patient. So some final thoughts on the development of paroxysmal sympathetic hyperactivity. We don't know what the role of hormones is, aside from the adrenal stress response. We see that in a small subset of patients with severe brain injury, they have pituitary dysfunction as early as a month after injury, but it can occur in a delayed fashion. We don't know what role hormones play in the development of the storming episodes. We don't know what the role of non-pharmacologic treatments are. Are there special positioning techniques that we can use to help minimize it? Does the hip flexion really tend to make a difference? Does the application of cold help? There's all kinds of things that no one has even thought to look at yet to see if they're efficacious in managing even some of the symptoms associated with sympathetic storming. We are working to solidify the nomenclature. I know I tend to still call it storming because that's just what I've called it for so long, but the preferred name for it is paroxysmal sympathetic hyperactivity, or PSH. And then we really need to be more diligent in aggressively identifying and treating this as a neurologic problem and not as an individual cardiac problem or an individual temperature problem. And we need to recognize that the symptoms, when they occur like that in congruence, really tend to lead to a neurologic problem. They need to be treated as such, because delaying treatment delays recovery. So with that, I would be happy to entertain any questions that you might have, and I appreciate the opportunity to share this topic with you today.
Okay, we did have one question, but if anyone else has any questions, feel free to go ahead and type those in the question box, and we'll try to get to as many as possible. This question is, with the pupillary dilation, are the pupils still appropriately responsive? And then she sends again, withdraw the question if associated with DAI.
If I understand that correctly, yes, the pupils are appropriately responsive to light. They just tend to be bigger. but when you shine the light in them, they will still appropriately contract. And then I'm not sure what's meant by the DAI.
Okay. The next question just came in. Is medication treatment any different in pediatrics?
I believe, I don't do pediatrics myself, but a lot of this comes from the adult literature, but the treatment paradigms tend to be the same for pediatrics, but of course at much smaller doses.
Okay. Are there any new large clinical studies in the works that you are aware of?
There actually is a large study, and I'm blanking on, it has it has a catchy title, and I cannot think of the name of it right off the top of my head. But I'm a little concerned about the design of the study. It's actually medicating people in the first 7 days, and it's medicating all comers with severe brain injury in the first 7 days. So my concern is that they're going to medicate people who don't even have sympathetic storming or PSH. And then number two, they're medicating them for 7 days, which really it doesn't even appear in most patients during that time. And then they're not going to medicate them later when it's more clinically evident. So it'll be interesting to see how that study turns out. But I do have concerns with it, with its overall design.
Okay. The next question is, how is elevated temperature best managed? Cooling blanket, and what about hypothermia?
So hypothermia in general has never been well proven to control ICP or improve neurologic function. And so usually that's left to individual provider discretion to determine if that's an appropriate therapy. I would say that by the time you really get into fully exhibiting sympathetic hyperactivity, that probably doing invasive or highly technical cooling is probably not an appropriate therapy. However, you can use cooling blankets and ice packets, especially because it tends to be transient. And then you can use acetaminophen, although it may or may not be very helpful. And then I know this is very provider dependent, but we actually use ibuprofen even in our fresh cerebral hemorrhages from any source. We find that it tends to work a little bit better than acetaminophen. We haven't noticed any complicating bleeding issues, but I know that there's a lot of neurosurgeons who will not allow anybody with neuropathology to have ibuprofen. But we do see that it works a little bit better than the other mechanisms.
Okay. Next question. Where did you find the brain picture?
Google.
Okay.
I think I Googled brainstorm, and I think that's what I got.
Okay. The next person is asking if you can review stage 3.
So stage 3 I'm actually less familiar with because it tends to occur later in the recovery course. I just do acute care, but it's typically seen in rehab or even after discharge from rehab when you have less of the motor complication. So all that dystonia and the posturing, that tends to go away. And so that kind of signifies essentially the resolution of the whole disorder, if you will.
Okay. Another question is, can storming occur even if the patient's GCS is 13 to 14?
Generally not, because it requires dysfunction of deeper brain structures. And so if you have disruption in those deeper brain structures, they tend to be not awake. So it's really related to people who are comatose and have significant pathology deep within the brain. And I wonder if maybe in those higher level patients, the mild or even the moderate brain injuries, it may have some similar phenomenon, but in the literature it has never been described in that population.
Okay, and one I think that may go along with that a little bit that just came up is it unusual to last for more than 6 weeks?
No, it can last that long, and like I said, even up to 5 years. At least one study showed that it lasted up to 5 years.
All right.
What we tend to see is that the symptoms stabilize over time, and so once you get them on an appropriate medication regimen, they tend to be asymptomatic or at least well controlled. I'll tell you that we sent a young lady who had very bad storming episodes to a facility that it was basically a nursing facility, and they weren't familiar with the gabapentin, they weren't familiar with the bromocriptine, and so they stopped it all, and she ended up at another hospital and got this $1 million cardiac workup, which of course was all normal. And so those medicines, even at fairly low doses, can really have a dramatic impact on the symptom presentation.
Okay. The next question, what about anticoagulation because of the immobility issues?
So I'm going to speak kind of in a broad, not specific to storming, but really prophylactic chemical anticoagulation is recommended for all patients with brain injury who are immobile. The question is, when do you start it? And I believe that the DVT guidelines that are going to come out by the end of the year are probably going to say within 72 hours of a stable CT. So you don't want to start it right away. You want to show that their contusions or that their subdural is stable, not getting any bigger, and then it recommends generally the mini doses of low molecular weight heparin. So we tend to use enoxaparin, just 40 milligrams once a day, instead of the traditional trauma dosing of 30 milligrams BID.
Okay, and forgive me if I mispronounced this. You mentioned the study about Haldol. Do you have a reference for that? We sometimes struggle with getting our clinicians to not give Haldol to TBI patients.
I do, but I don't have it handy. If you, is there a way they can get me their email and I can share that, or is there a way I can post it later?
I have her name. I can have you send it directly to her. Okay, and let's see, I think there's a couple more. I've witnessed this occurrence go on at times for 2 hours, at times despite medication use. Is this common, or should other interventions take place? And if so, what should they be?
It all depends on the symptoms that you're seeing. 2 hours is a really long time, and it may mean that they require different medications or higher doses of medications. But 2 hours is a long time to let that catecholamine surge go on. You can start getting into subclinical organ damage with that. So it may be that you need to, number one, reevaluate and make sure that you're truly seeing storming and not some other medical complication. Number two, maybe reevaluate your medicines, and perhaps you need to try a different cocktail. Because I don't know how many times I've started on what my usual are, and a week later I've kind of gotten rid of the first drug and added a different one because the combination wasn't working.
Okay. The next question, and they're still coming in, so we've got about 5 more minutes. We'll get through as many of them as we can. The next question, what is the course of therapy for the use of amantadine?
Amantadine?
Yes.
That's a good question. So the course of therapy, amantadine, we use it because it releases dopamine in an excitatory capacity in the brain. So number one, we use it in the sympathetic storming to kind of help. It sounds counterintuitive, but you want that inhibition loop to open up, so you use it to open up the inhibition loop for that. However, amantadine, there was a big study that was done about 1.5 years or 2 ago that showed that amantadine actually improved outcomes in a rehab setting after a brain injury. And so a lot of people are even using it in their patients who don't have storming. They're just using it as a neurostimulant following brain injury. Most of the time, you should wait until the patient's ICP monitor is out, because you don't want to stimulate a brain that's still having ICP issues. But once your ICP monitor is out and you're ready to start moving your patient forward, then you can start it. And I think a typical dose is 100 milligrams twice a day. And I don't know how other facilities do it, but if we just order 100 milligrams BID that goes on a 9 a.m. and 9 p.m. dosing schedule, and we don't want to give a stimulant or anything perceived to be a stimulant at night because our colleagues would hate us. So what we have a special built-in procedure when we order amantadine for brain injury or neuropathology as a neurostimulant. It's given at 8 a.m. and 12 noon so that it can help with their awareness during the day, and then it will let them shut down a little bit more to sleep at night.
Okay. The next question, who is providing the DVT guidelines?
Neurocritical Care Society. They are in final review right now. They should be out at the end of by the end of the year. But there's many, many papers on the use of chemical anticoagulation. Of course, all patients should have mechanical prevention, TED hose and compression boots or compression sleeves, as long as the orthopedic injuries allow upon admission. And then the debate currently is how much and when to start the chemical anticoagulation.
Okay. Our facility uses the Dilantin therapy, typical for 7 days post-initial insult. Is there any correlation with the discontinuance of anti-seizure medication and the presentation of symptoms for PSH?
No, there is actually literature to suggest that the use of anti-epileptic drugs, not just Dilantin or phenytoin, actually has no effect on storming symptoms. I believe they looked at a couple of different anti-epileptic drugs, and it had absolutely no effect on the symptoms. So no, I don't believe there's association with discontinuing that at 7 days. And just for whoever asked the question earlier about the big study, it's called the DASH trial, DASH after TBI. It's a randomized controlled trial called Decreasing Adrenergic or Sympathetic Hyperactivity After Traumatic Brain Injury Using Propranolol and Clonidine by Dr. Patel. And it's actively enrolling.
Okay. I think we have one more question that I see. For a bad storm, and if the patient is appropriate, would you ever use IV propranolol?
Propranolol?
Yes.
I don't see necessarily a reason not to. It's not, we don't start it at our facility, but if the patient needs it, I don't see any reason not to avoid it. And sometimes, you know, normally with brain injury, we like to start drugs at low doses and titrate them up. This may be one instance where it's better to start at a higher dose just to get symptom control and then to taper it until you find a happy place where you have no to minimal symptoms, but you're allowing them to wake up. And it may be that, you know, initially you may need to use more benzodiazepines, more lorazepam, more midazolam, drugs like that, just for patient safety. But you want to be able to get those off as soon as possible to allow, to facilitate neurologic recovery.